Today, we have a very distinguished speaker, Dr. Jacqueline Saw, who is a clinical associate professor at the Division of Cardiology at UBC. And she's also the program director for VGH Interventional Cardiology Fellowship Program and also head for VGH Cardiology Clinical Trials Research. Jacqueline and I got introduced through a joint colleague, Dr. Teresa Sang, and I had a meeting with Jacqueline who posed me a very, very challenging AI question. And I thought that instead of me trying to kind of speculate how to solve this problem, we should actually invite some of the experts and the students who are actively working in this domain and connect them with Jacqueline and her team so that we can see whether there are any collaboration opportunities. The topic, I guess, of the talk today is related to the coronary artery disease. And I'm looking forward to hearing, I guess, and learning about this disease, as well as how Jacqueline magically can do her procedures, I guess, that seem to be, you know, more like a Star Trek work these days to help patients. So without further ado, Jacqueline, please take over. Thank you so much.
Great, thank you so much, Parang. I'm just sharing my slides here now, so let me know if you can see that. You got that?
Yeah, we can see it.
Perfect, wonderful. Well, thank you so much for having me and present to your group, because I think you are right, this is a very challenging domain, and I think it's so critical, and I think that will help patients dramatically in terms of improving our ability to pick up this condition. And because, you know, you can't treat something if you can't diagnose something. And so that I can just launch into why this is so important to study this. And we're hoping that with your team's help, we can work into whether we can use, you know, machine learning to help diagnose this challenging condition on coronary angiogram. So first of all, you know, this condition is called spontaneous coronary artery dissection, or SCAD for short. And SCAD basically is a separation, a tear in the artery wall that supplies the heart. And this tear can occur in any of the layers of the artery. And the three key layers are intima, media, and adventitia. So this tear can occur in any of these layers, is a spontaneous tear that is not due to, say, a car accident or iatrogenic, meaning from medical instrumentation. It is not due to cholesterol, okay? And once this tear occurs, blood then accumulates in the wall of the heart artery that then compress the true lumen, and therefore it impacts the blood flow to the heart muscle. And when that happens, a heart attack can occur, okay? And so this condition was first reported back in 1931. And over the past, 8 decades, essentially, we've done a very poor job in diagnosing this. It wasn't until the past decade that we have improved in our ability to pick up this up on angiogram. And as a consequence, there is a lot of myths and misunderstanding about this disease condition, including saying this disease is rare and that it mostly affected women who are postpartum and it had high fatality. And we know these are all wrong now because of our increased ability to pick up recently and our ability to now better understand what some of the natural history is related to that. And now just to put in light how important this condition is. So this SCAD is primarily a disease that affects young to middle-aged women. When we look at causes of heart attack, so now that we're better at looking at angiograms for this condition, when we go back and look at angiograms of women presenting with heart attacks, we see that SCAD is the cause of these heart attacks in young women less than age 50 to less than age 60. It causes heart attack in these women in about a quarter to a third of cases. So it definitely is not rare. And so when we look at our BC population history, you can see the increase in the pickup of SCAD in our population over the past, couple of decades. And you can see that, who are affected, it's not really the men. So when men have heart attack, is usually due to cholesterol, right? What we call atherosclerotic heart attack. And when women have heart attacks, if you're older, say you're older than 50 to 60, typically your heart attack cause is also due to cholesterol, much like men. And usually when women have heart attacks, they present a heart attack 10 years older than men when it's due to cholesterol. Now, the exception is when you have younger women. So here you can see women less than age 55, when they have heart attack, SCAD is the cause in at least 14%. And this data is actually, I would say, still underreporting. There's still a lot of missed cases of SCAD that's not reported in that series, all right? So who gets SCAD? Again, it's primarily a women condition. So women accounts for about 90% of these types of heart attack. The mean age ranged from 45 to 55. And when we look at our large series of 750 patients that we enrolled prospectively in a Canadian SCAD study, we see the age range like a bell-shaped curve. It ranges from 24 to 89, but the mean age is 52, okay? So again, this is a young to middle age condition. So now what causes SCAD? So I've already said this is not a cholesterol problem, okay? So it's not due to our bad diet and our genes related to that. It's due to a different condition. And the arteries in the heart tear because typically there is something that has weakened the heart artery wall that makes it more prone to tear. And then usually on top of that, there is an additional stress, what we call cardiocirculatory stress, like emotional stress or physical stress, lifting really heavy weights that then provoke the tear when your arteries are already weak to begin with, okay? So what are the disease processes that then cause these arteries to be weak? So these are the various examples. One of the most important link that we've identified is this condition called fibromuscular dysplasia, or FMD. And this disease is a systemic disease that actually affects 5% of women, and that's also underdiagnosed. And in the heart arteries, it can cause weakening of the heart arteries and therefore prone to this tear. So in fact, we find FMD in our SCAD patients in about 60 to 80% of our SCAD patients. So this is the most predominant cause and link to SCAD. Now, the other causes are other forms of connective tissue disorders like Marfan syndrome, Ehlers-Danlos, other systemic inflammatory disease, potentially like lupus or Crohn's, or in patients who have multiple pregnancies, like those who have had 5 or greater pregnancies and delivery. And so each time you have a pregnancy, you have really high estrogen and progesterone in your system for a prolonged period of time. And also postpartum after, vaginal delivery, there's a lot of strain involved. And so those are all additional stress that can weaken the heart arteries and therefore provoke and cause a tear. So these are the number of different causes of why it's mostly a women condition that cause a tear. So now the question is, how do we diagnose SCAD? Now, the gold standard to diagnose SCAD is by coronary angiogram. And this is the age-old tool that we've had for decades and decades. Now, unfortunately, even though this angiogram is widely available, it's still an imperfect test, especially for a disease that affects the wall of the artery, okay? And why is that so? Okay, so if you think about coronary angiogram, it basically, we put catheters. Here's an example. We put a catheter, and we engage the heart artery, and then we are injecting iodine contrast to fill the inside of the artery. So what we're seeing here, this is an outline of the heart artery. And I'll show you more examples later. Okay, so this is outline of the heart artery, the inner lining. So we're looking at the lumen. We're looking at the lumen, the interior lining of the artery. We're not looking at the wall. Okay, and the resolution of coronary angiogram is 0.1 millimeters. So that's about 100 microns. Okay, and obviously the heart is not static. The heart is beating. Okay, and so it's moving around, and it's a 3-dimensional structure, whereas an angiogram is really a depiction in a 2-dimension format. Okay, and so we have challenges looking or diagnosing blockages that are minor or what we call eccentric. So it's sort of affecting not in a circular plane, but more of a concentric plane or eccentric plane, I should say. And for small vessels, because the resolution is only 0.1 millimeters, it can miss, smaller arteries or microvasculature. And in fact, we know that heart attacks, in about up to 15% of cases, when heart attack occurs, we have relatively normal looking arteries because the angiogram is not good enough to see these smaller vessels or minor blockages. That's not due to rupture of cholesterol plaque, but due to other causes like more of a erosion or other causes like a tear. Okay. So when we look at angiogram pictures, coronary angiogram pictures, this is a sort of a schematic of what we normally would see. Okay, so these are the various heart arteries that supply the heart muscle. The way we picture this is by, as I said, put a catheter here, and then we inject X-ray iodine contrast, and then on the X-ray machine, iodine contrast appears dark. So that's why we see these branches of arteries. We're basically outlining the inside of the arteries. And by taking different projections, so what we're doing is, so this is a patient on a table. The top part is the camera. The bottom is the X-ray source, okay? So by rotating the camera in different angles, like here, we're going to the right of the patient. It's called right anterior oblique. Here, we're going to the left of the patient, or left anterior oblique. So when we rotate, we then see this two-dimensional picture of the heart arteries, which is a three-dimensional structure. So we can see rotation in multiple angles, okay? And typically, when we do an angiogram for a patient, we would do at least 4 to 6 or 8 or even more angiographic projections, so we can get an overall better understanding of all parts of the major arteries, okay? So let me show you a normal angiogram. This is what a normal angiogram looks like. So here we are taking a picture with the camera on the right side, right anterior oblique, and caudal, meaning we're looking from the belly. So we're looking from the right of the patient and the belly. And this is the projection. So we're seeing the left main artery, we're seeing the left anterior descending artery, we're seeing the circumflex artery. And also what you're seeing is really smooth arteries, right? So you're seeing big train track from where we inject, this is a catheter, we inject the iodine contrast. The iodine contrast starts from the left main, it goes down all the way to the LED and all the way to the bottom of the heart. And you can see it's nice and smooth. There's no narrowings here, okay? These are all normal branches, septal branches, obtuse marginal, LED. And then we then put a different catheter to the right coronary artery and inject, and this is the right coronary artery with its branches, okay? And then we would do what we call left ventricular angiogram, where we put a pigtail catheter inside the chamber of the heart, and we look at the squeezing function of the heart, okay? So here we can see what part of the wall is not squeezing normally. And this is an example where everything squeezes normally. When a heart pumps, 60% of the blood goes out of the body. That's normal. Less than that is considered, left ventricular dysfunction. So this is what a normal angiogram looks like. Now, in patients with cholesterol type of heart attack or blockages, the appearance can be something like this. I just put you at various examples. You can see, okay, well, this artery is not smooth like the other example I showed you. There is actually a severe blockage over here, okay? And there's minor blockage. You see how it's a bit irregular. And this artery, I've done 20,000 angiograms, so I can see right off the bat, this is abnormal. This is actually larger than normal. So this is what we call ectatic or ectasia, or almost aneurysmal. Not quite to that degree, but it's ectatic. And then there is a minor narrowing over here. So this is a bit subtle, but I will show you something that's a little bit more significant. So here you see, okay, there is a tight blockage over here. Don't need a lot of training to see, okay, this part of the vessel is almost completely blocked. This is what we call 90% blockage in that artery. And you can see some minor diffuse, minor narrowing, okay? And similarly, that branch over there, this is now depicted in a different projection, what we call a cranial projection. And now we see this blockage here, that's 90% tight. So this blockage is characteristic of a cholesterol type of blockage, okay? And then this is the right coronary artery. And so when we inject, you can see there's some minor narrowings, there's minor narrowings. This is what we'll call 30% blockage, not that severe, okay? So this is what a cholesterol blockage would look like. And so the question is, how does a SCAD artery look different from a cholesterol type of blockage? So SCAD, as I said, is a tear in the artery wall of the heart. So here you see, okay, the tear occurs, you get a flap, Now blood, instead of going in the main lumen, now is going outside of the lumen, inside the wall of the artery. So this is the most simplistic way of explaining it, right? So this is the artery. Again, blood is flowing. Now you have a tear. Now blood, instead of going through the main lumen, is going outside, okay? So you can imagine when blood goes outside, it's gonna compress the main lumen, okay? And this picture is what in the old school, when I was taught as a medical student, like 20 years ago, more than 20 years ago, I was told when you're looking for a dissection, this is what you should see on an angiogram. You should see these multiple lumen. See, this multiple lumen is due to this flap, all right? Okay, but lo and behold, you know, it took us many decades to then understand that, well, that is not the most frequent presentation on angiogram for SCAD. Okay, so this is the textbook definition, what we call pathognomonic, but this is not the most frequent presentation. What we learned over the past decade is that this tear is not necessary. This intimal tear is not necessary to come from the main lumen to split into the false lumen. In fact, you can have spontaneous bleeding from blood vessels that supply the wall of the heart arteries that spontaneously bleed, and then it bleeds into the false lumen without even needing the tear. And then there's a chicken and egg theory that, well, you actually maybe don't need the tear. You actually bleed into the wall first, and then because of the pressure in the false lumen, it then split into the true lumen. That's why you see this intimal tear. So the chicken and egg theories, which came first, we don't actually really know. All we know is that in most cases of SCAD, we actually have blood in the wall, but we may or may not see intimal tear. In fact, when we did intracoronary imaging, more specific imaging, we see intimal tear in less than, say, 20% of cases, all right? So really the feature on angiogram that we've been missing for decades is what we call an outer compression image, meaning that we're looking actually at blood. This is actually blood in the wall of the artery that's compressing the true lumen. So we're actually should be looking for this long narrowing that we've not been looking for decades and decades. That's why we've been missing this condition, okay? And you may even not pick this up. It took me a long time to pick this up. So there is minor narrowing from where the arrow starts and the whole length of it, and then it normalizes, okay? So this is appearance of narrowing by compressing from the outside. What I'm showing here is a special modality called optical coherence tomography, that we have to put a wire in the heart artery, put a catheter in, and then using light technology, we're then actually seeing the wall of the artery. Okay, this is very invasive. Not all laboratories would do this, okay? And so this allows us to then see the actual wall. So this is actually blood in the artery wall representing where this narrowing was, okay? So to highlight how challenging this was, and this is back 10 years ago, April 2011, when I saw 3 young women where they had these blockages. You see this blockage here? And this blockage, this looks like cholesterol blockage. You know, if you're not trained to look at SCAD, you would think this is cholesterol and you just put a stent in, which is the wrong thing to do for these patients. There's this long narrowing over here. And this is also not what we were told as a medical student to look for tear. And it was only back 10 years ago when we acquired this intracoronary imaging, this OCT, before then we were able to say that this is actually not cholesterol, this is actually blood. And this is a huge light bulb that went off 10 years ago for me. And at that point, I learned this is 3 women in 2 weeks who presented with a heart attack. And all 3 cases were not due to cholesterol. And it clued in, number one, this is not rare. How can 3 young women present to a heart attack to Vancouver General Hospital under our care here and to call this rare? Obviously, we made some major mistakes in the past century about this disease. We're not picking it up, all right? So we then, started doing a lot of intracoronary imaging to learn. So I just showed you an example on the left side. This orange figure is from a light technology called Optical Coherence Tomography that has a resolution down to 10 to 20 microns. And that allows you to look at the wall of the artery. Remember I said the angiogram resolution is only about 100 microns. So this is way better than an angiogram. This is an older technology called intravascular ultrasound. It's a bit more fuzzy. It has a lower resolution of about 200 microns, okay? And this allows you to look at the artery lining in a different way than the angiogram does, okay? And because of these modality, this allowed us to then say, okay, this is what it looks like on these imaging. Now we can go back and look at the angiogram, because the angiogram is a more widely available modality to diagnose heart attacks, whereas these intracoronary imaging tools takes a lot more work. You need to put wires, you need to put catheters in, and it's a lot more invasive for patients and risky. Okay, an average interventionalist or angiographer who does not do these stent stuff would not be able to do this imaging modality. So this modality is not available for all patients with SCAD, but an angiogram is. So we need to be able to learn how to diagnose a SCAD on angiogram from learning from these more, informative tools. And this is what we did. So what we learned in the past decade is that, number one, SCAD has been underdiagnosed for all these decades because, number one, we were not good at picking up an angiogram. We were not doing these IVUS or OCT to know better. And we were looking for the wrong picture. We're looking for these intimal tear, but we're not looking for the compression type. And also, for many years, we thought women should not have heart attacks, especially young women, right? And again, that's also wrong. Young women can have heart attack. They just have a different cause for the heart attack. And so this is just the example of what we're trying to show you here. It's a long, diffuse narrowing, okay? So that's where a lot of the challenges is. So when I first started interested in this condition, I had to, number one, start categorizing and classifying this condition so people are better at picking it up. So I came up with a new classification where we call it type 1, 2, 3 to allow us as angiographers a better tool to be able to pick this up just on angiogram, okay? So I named the type 1 as the classic textbook, old school. This is what we were taught in medical school. You need to see that multiple lumen because blood is going outside the wall and is staining the wall, okay? That's why we see this multiple lumen as opposed to a smooth narrowing. And we call the type 2 the long diffuse narrowing. So if you can sort of see this, you can see this is normal artery down here. And then boom, right to this point is when the artery becomes narrow. And it's not just narrow, it's short, it's narrow long. From here all the way to here is narrowed, okay? And then it normalizes, okay? So there's normal vessel beyond this long narrowing. So this is called type 2A because there's normal vessel before and after. Now type 2B is also long narrowing, but the long narrowing starts here, but it goes all the way to the bottom of the artery that is so severe, it actually occludes, blocks the entire artery, and it prunes off completely. So there's no normal vessel beyond. That's how we differentiate type 2A and type 2B. Now type 3 is just a narrowing that is not really long, okay? So you have the narrowing. When it's short like this, it looks like cholesterol type of blockages, and it's challenging because this pattern you don't see with cholesterol. This pattern you see with cholesterol, okay? So what we call mimics atherosclerosis. So really the key way to differentiate this from cholesterol would be to do an imaging modality like the OCT to tell that this is blood and not cholesterol, okay? But we don't want to do this all the time because, as I said, it's risky. So we want to limit doing this additional imaging only for people where we can't tell from these two examples, okay? And that's how we came up with the algorithm that if you have this type 1 multiple lumen, you make the diagnosis of SCAD. If you don't have that appearance, then you look for the long diffuse narrowing, okay? If you have the long diffuse narrowing, yeah, you can pretty much make the diagnosis of SCAD after you had seen a lot of these so that it becomes a pattern recognition, you know how to diagnose this. Type 3 is when it looks like cholesterol, and even I'm not so good. I can't even tell it was typically type 3, and I have to do a few things. I would have to either do this OCT imaging, or I would have to repeat an angiogram in a few weeks and see if it's still there. The good thing about SCAD is that these arteries heal on their own. In fact, if I were to repeat an angiogram in 4 to 6 weeks, over 90% of these arteries will heal, okay? That's why we need to differentiate cholesterol plaque from blood. If it's cholesterol, it will never go away. If it's a cholesterol plaque causing that blockage, you need to put a stent in to fix it for a heart attack. But that's not the case for SCAD. That's why it's so essential to differentiate the causes of heart attacks in these young women. So over the past decade, I've done a lot of research on this condition, and I've got multiple grants, including the CIHR grant and Heart and Stroke grant. And this allowed us to actually do a prospective study of 750 patients who were enrolled throughout Canada, in 22 sites throughout Canada. So this is called a Canadian SCAD study. We finished enrollment over 5 years. We published our 30-day outcomes in the past, actually 2019. And so of these 750 patients, we had 1,000 dissected arteries that were correlate adjudicated by our angiographic core lab by John Mancini, okay, at UBC. And so of the 1,000 dissected arteries, you look at the angiographic patterns, 60% were the type 2s, okay, so long diffuse blockages. 29% were the type 1 textbook, multiple lumen, and about 11% were the type 3, okay? And intracoronary imaging was required in about 8% of these patients, mostly for the type 3s, okay? But you can see most of the angiographic appearance of SCAD is actually the long diffuse narrowing type of blockages, okay? So that's why, if you're only looking at this multiple dissection lumen like this, you're missing 70% of SCAD, which is why we've done a poor job in the past decade, because we didn't know these existed until about a decade ago. And the other features we help look at is, when you have a blocked artery, the muscle supplied by this artery is going to die or is not beating as well. Okay, so it's what we call wall motion abnormality. So it's not beating as well. Okay, and 85% of the time, that part of the wall supplied by this artery is not beating as well. So we will be able to see it. And so if this narrowing is subtle, we see is not beating as well, we can go back and trace where is that blockage. So that's one tool for angiographers like me to go back and look if it's not quite as clear. And any heart arteries can be affected. These are all the different segments of heart arteries, but the most common artery affected is the left anterior descending artery, okay? And then about 13% of cases, more than one artery can be dissected, meaning it can be one artery here and it's another artery here, and they're not connected in the sense that it wasn't like it started here and it goes down here and it affects here. So multi-segmental non-contiguous means two separate segments that are not connected. And that can occur in about 13% of cases, all right? So let me show you some of these examples, all right? And this is where we're hoping that AI and machine learning can help identify this, because humans don't generally do a very good job. And you need to see a lot of these before you can diagnose this, okay? So this is what we call type 1, okay? Maybe you've seen enough of these examples now, but you see, okay, well, this is not normal. Like this is normal here until it goes up to this point, okay? You see now it stops being normal. It starts getting narrowed. It's narrowed down to here. And look, there's a staining outside of the artery wall. So the moment we see staining outside the artery wall, this is type 1, okay? You make the diagnosis of SCAD. You don't need to do anymore, okay? All right, so this is type 1. Show you another example. So here, normal artery, normal, and then boom, right here becomes abnormal. It's a long segment of abnormal, long segment of being compressed from the outside. And on top of that, you see this dye staining in the wall outside of the lumen, okay? And so this is also type 1. You can see another example of staining here, okay? This is two areas of staining, okay? And one of the hallmark of SCAD is that it doesn't affect all arteries, and the other arteries are usually free from cholesterol plaque. So you can see the other arteries is nice and smooth, okay? There's no narrowings. This is nice and smooth in the left anterior descending and the diagonal artery. This is the right coronary artery, is nice and smooth, okay? This is really, the SCAD only affected this one arterial segment with no evidence of cholesterol plaque elsewhere. And so here's another example, because I have so many of these examples. You can start seeing, see that dye hang up there? Okay, so this is a long diffuse narrowing from blood in the wall, and then now you see the staining out here, okay? And here's a different projection showing the dye staining in multiple lumens. Now you can see the staining is outside the main lumen, okay? And here's the example showing, well, we're seeing the pumping function of the heart. The apex of the heart is actually not beating, it's actually ballooning out. And this corresponds to this area, because this artery supplies the apex of the heart. So it's corresponding to this, okay? So this is type 1. And type 1 can be very subtle, okay? This is what people have missed as well. You see the artery is actually blocked over here. And if you keep sending along now, you see the staining over here. This is a lot more subtle now, okay? And there's also another staining here. This patient actually had 2 vessel SCAD, okay? This is just another picture of it. To see that staining here, this is the septal branch that has a type 1 SCAD, and this is the LAD that has also a type 1 SCAD. So this is 2 vessel SCAD, all right? And I would say that most people would have probably not seen that staining over there. They would just call the artery being occluded. And this is just a different picture showing the type 1 stain. You can see it's very subtle, it's right there, okay? Humans may not pick it up, but I think machine can pick it up, And then the type 2A is a long narrowing. Okay, this is normal here. And right, this is normal. And then boom, this whole part here is abnormal. This whole segment here, okay, long segment, abnormal. That's because of compression on the outside. And because there's a normal artery before and a normal artery after, we call this type 2A. This is a pretty obvious one. And this is also an obvious one. You see, this is normal, 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 and then boom, it becomes abnormal here. And this whole segment here is abnormal, okay? And says, and then there's normal vessel after that. So this is also type 2A involving the LAD artery. Okay, here's a different example. You can see this normal, normal, and then boom, it becomes abnormal, long narrowing. Okay, this is also type 2A, smooth narrowing. Okay, and here's another example, more subtle now. Okay, that's why humans miss it. Look, this is long narrowing over here. Okay, but it's subtle. It's not 90%, like the last examples I showed you. It's more like a 30% narrowing. You see, it starts from here. This is abnormal. Okay, and it takes a while. And these were the cases in the past. I had to do intracoronary imaging to show there's blood in the wall to prove to my colleagues that these were tear. Okay, but I want to show you this particular example because it's very important. So this is minor narrowing due to SCAD. But look at the front artery. This is the LAD, which is normal back then. Okay, all right. So this is 2 years prior. And then 2 years later, this patient presented with another heart attack. This is the same patient. Look at his artery now. Now it's completely normal. Okay, let me just go back. You look at this artery. Now this is normal, okay? But you compare to 2 years ago when she presented with a SCAD. Let me go back, sorry. See that narrowing? It's subtle, okay? It takes a while to appreciate that. And, but you see that segment? That's now normal 2 years later. But look at this vessel, okay? This was normal back then. Okay, let me just show you 2 years later. So that part normalized, but there's a new type 1 dissection over here. Okay, there's a new type 1 dissection here. And on top of that, the front artery I showed you was normal before, no longer normal. There's a diffuse type 2B dissection from the LAD all the way down to the apex. On top of that, when you look at the right coronary, she has another blockage here, which is a type 3 dissection. So when she came back 2 years later, she had multi-vessel SCAD involving 3 different arteries. And her old artery that had a SCAD had healed. Okay, that's how dramatic this disease is, all right? And so this is a different patient. This is a patient where I'm trying to show 2D SCAD. So this is actually the long diffuse narrowing. If we're looking at this in isolation, a lot of angiographers would miss this because it looks like maybe a normal tapering of a vessel. But this patient, a year later, actually the artery healed from the tear. So this is clear difference between healing and the original SCAD. Okay, you can see how it can be subtle and how humans can miss this. Here's another example, normal, 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 all the way up to here, and then boom, there's a tear that goes all the way down to the apex of the ventricle. This is a type 2B SCAD, all right? And here's another example. And I tried to collect as many as possible so you can get an understanding of what these angiographic images we're trying to pick up with AI. And so this is long diffuse narrowing, which is subtle for human eye, but it is there. And in the same patient, this is also long type 2B dissection. This patient had 2 type 2B dissections in the same patient, all right? And very subtle, but you can see in this left ventricular angiogram, this segment of the wall is not moving as well, okay? Subtle, but it's there. And this is another example of type 2B where the dissection is down here, okay? And it affects all the way down to the bottom of the heart. And this is the corresponding part of the muscle that is not beating well, okay, related to that artery. And this other vessel is just showing they were normal, okay? So this is type 2B. It's a bit sometimes hard because it may mimic natural tapering of vessel. Now type 3 looks like cholesterol. So this, you see this focal narrowing here. It's about 70%, 80% block. Normal vessel before and after, and it's short. It's less than 20 millimeters, and it looks like potentially could be cholesterol. Okay, so this is an example of that. And these are other examples of type 3. And this narrowing over here, the other vessels are all normal, but there is this narrowing over here is a type 3. It's so short. Okay, and here is another example of very minor Okay, this is actually SCAD, but minor, 30-40%. The next stage you presented with extension of that tear. Okay, so these are more subtle examples. This one is not quite as subtle. This is a type 3, but very tight. You see this narrowing right here? This is a 90% blockage, but relatively short. And one feature that's really pronounced here is how tortuous. This is like a Mississippi River, okay? You don't get this Mississippi River in most patients, especially in the men. And this appearance is classic for a disease called FMD affecting the heart arteries. This is a man. Number one, I said FMD affects mostly women in 90% of cases. Men can have SCAD as well. And when men have SCAD, 50% of the cases is due to underlying FMD. So this patient has FMD, which is why his arteries are like this, which is very abnormal. But he had a SCAD here, and about a year later, when we repeated the angiogram, the SCAD healed on its own. That narrowing is no longer there. Okay, so this is a type 3 example of SCAD. Now, so I think I try to show as many examples as possible. I know machine learning for coronary angiogram is relatively new, and I think there are a lot of challenges. This is I actually spoke to this group several months ago. They're in China, and they do a ton of angiograms, and they've done machine learning for cholesterol types of blockages. They've looked at a data set of 20,000 angiograms, and they had, angiograms with cholesterol type blockages, and they were able to train and look at this. I don't know all the details in this study. This paper is accepted for publication, early publication. I can forward it to you. And I talked to that group about potentially looking at our SCAD arteries, but because this is an external group, this is in China, there's a lot of data restrictions in terms of forwarding stuff out, and different group altogether. So I'm a bit reluctant to do that with other cohorts. And so what we have in our group is we now have over 1,200 patients in our SCAD registries, and we have a total of basically close to 2,000 SCAD arteries that we have that we have available, that potentially we can help utilize machine learning to diagnose it, because as you've seen, humans are not really doing a very good job. And so is there a way of utilizing machine learning to help us with that? I'm not sure if I stopped sharing screen. I don't know what I did over here. Are you able to see me without the screen?
Yeah, your screen's gone, but
okay. Good. So that's all I have to show. I try to, be practical and show you a lot of angiogram examples, and then see, if this is feasible for what the group can or can't do here to help facilitate using machine learning.
Thank you so much, Jackie. I mean, this is a fascinating, I guess, problem, and I like to really hear AI experts such as Roger, who are in this call, I guess maybe ask some questions. Maybe I can start by, I guess, asking a couple of questions, I guess, so just I better understand. One is that I guess it's the heart flow technology. I'm sure you're familiar with it through St. Paul's. I guess they have the technology. Maybe I can show what they do. So in heart flow.
Is that the FFR CT?
Yes, they do. They use contrast CT, and then they visualize, I guess, the heart vessels, I believe. And can that technology not be used, I guess, for maybe I could put it in the chat box for everybody to see. So what can that technology not be used, I guess, for this kind of, I guess, diagnosis?
Yeah, I would say CT imaging is not good for diagnosing SCAD. And CT resolution is about, the voxel is about, 0.3, 0.4 is already lower than coronary angiogram. And so when SCAD affects mostly smaller, mid to smaller vessels, and not in the proximal part, so meaning it's affecting smaller arteries, it's very hard for CT to interpret. I am a CT interpreter as well. And I would never do CT as a first-line imaging modality for SCAD, because we think coronary angiogram is bad, CT is like 50 times worse. And you miss it for sure. MRI, you don't even think about MRA. It's just pathetic. So we don't even use MRA to diagnose coronary arteries. And CT is generally good to rule out disease, but it's not good to rule in disease. Okay. And
Okay.
so especially for SCAD, not the go-to tool. And yeah, and then flow, like so the flow imaging, like using FFR to predict blockages, it's useful for cholesterol blockages, but for SCAD arteries, it's not necessarily the flow is the problem. We need to diagnose the blood in the wall, and so we need to look at the narrowing.
Okay.
Yeah.
The second question I have is that, is there some kind of a confounding relationship between what you see in angiogram and at the end what you would see in echo? In a sense that I assume the changes in the arteries, it would eventually affect the heart function.
So what it is the heart muscle does not differentiate why it's missing blood. Okay, it doesn't differentiate what's the cause of ischemia, what's the cause of the heart attack. Any blockage in the heart artery, be it from a blood clot that just blocked it in the center, or the narrowing is due to cholesterol, or the narrowing is due to blood, it will result in the wall of the heart not beating as well, right? So what we call hypokinesis or akinesis, meaning it's completely not missing, is akinesis. Hypokinesis means it's just weak, beating but weaker. And ultrasound, echo, is just looking at the weakness, it's just looking at the beating, okay? But it doesn't look at what is the cause of that. And that's part of it. When we look at the left ventricular angiogram, we're doing the same. We're looking at where the part of the heart is not beating. And then we can trace back and look at the artery. So the ultrasound helps with that, but it doesn't, it's not going to tell you why is lacking blood supply.
Okay, but then in terms of, I guess, a chicken and egg problem, do you get these patients after they get a formal echo that they, like, say, somebody like Christina?
Yeah, so it depends, because sometimes they get the ultrasound first, sometimes they get the ultrasound after they've had the angiogram. So it really depends. Okay. I would say that the ultrasound would not really help us in terms of diagnosing SCAD.
Okay. Okay. By the way, just an aside, I mean, I once attended a graduate student PhD defense in France, and the student had developed a robotic technology for imaging the heart. But looking at the technology, I didn't know how it would work for basically heart as a pulsating object. So I asked this question. I said, so how do you think this technology would work on the heart? And the student's answer was, the problem with the heart is that it moves. So that's a graduate student way of solving the problem. You stop the heart, yeah. But anyway, Roger, do you have any questions?
Sure, I can ask a question. Thanks very much, Jacqueline, for that really interesting talk. My question is, how do you envision AI being incorporated into the clinical workflow?
Yeah, because as I said, even angiographers like, my colleagues are poor at interpreting this. And so I would imagine creating a software, an application that on an angiogram, when you actually do the angiogram, like Toshiba or Philips or GE can incorporate into the software and say, okay, well, you plug this in or you upload this somehow into an application, and then the software can interpret and say, oh, that's where the narrowing is. That looks like potentially type 1, or it looks like potentially type 2 SCAD. Clue in, right? Then you can go back, and then the clinician can go back and say, oh, okay, well, I didn't really see that, but let me go back and look and say, well, is that potentially SCAD? Did I miss it? Should I bring the patient back for repeat imaging now to look at this, right? Or should I do an MRI to confirm it's actually a heart attack? Not say the cause of the heart attack, that it's actually a heart attack, or it's not due to myocarditis or an inflammation, for instance. So I imagine a software that will be very practical. After an angiogram, the clinician will just put it in, and then it helps them say, oh, maybe potential errors that you've missed. If it's obvious, someone won't do it, but for cases that are more subtle, hopefully the computer can perhaps do this.
Right. And would you imagine that would be helpful for clinicians at all levels of expertise, or just, okay?
I would say all levels of expertise, because if we can train a machine to really pick up more subtle stuff, I mean, sometimes I even have trouble picking up these subtle ones. And if we're unclear about the subtle ones, the key is highlighting and say, okay, we're not sure. So do we bring the patient back in 4 to 6 weeks to repeat imaging, or do we then do an intracoronary imaging at the OCT at that time? So I would say, for all patients where, I would even say, all women presenting with a heart attack, should have this this application, this software applied to see, okay, something is cluing in that this area we need to look at in more detail for SCAD.
Right, right. And is it true, or is it right to assume that the preference, or if there is a bias to the algorithm, that you would want it to tend towards sensitivity?
Yes, I would tend towards more picking it up than missing it.
Right, right. Okay. Thanks.
Jackie, I guess maybe one other question I have is that, is the management of patients different if it is, let's say, you mischaracterize a 2A versus 2B versus 3 versus 1?
No. So once you pick up SCAD, it's the treatment of the disease with SCAD. It doesn't matter what the angiographic appearance is like. The angiographic classification was purely to help clinicians pick up SCAD, right? And so once you pick up SCAD, the treatment is very different from cholesterol type of blockages, because number one, we don't put stents in, because when we try and put stents to fix the artery, it can squeeze the blood in the wall either before or after the stent and makes it worse. Okay, and in most cases, the SCAD artery heals on its own anyway, so it actually doesn't need stent. So putting stent in is actually the wrong decision for most patients with SCAD. And also, the medical treatment is different. Patients with SCAD don't have cholesterol. They don't need cholesterol pills like statins, but they should be on something like a beta blocker. All right. So the treatment is pretty different for SCAD patients versus non-SCAD patients.
Okay, so then that means that from a machine kind of learning point of view, it seems to be that maybe the first stop actually would be trying to separate all types of SCAD from cholesterol from normal heart. And then if you want to include, let's say, the normal angiograms and the cholesterol type angiograms, then what is the sample size that is available in your team? So you said it's about 1,000 cases that have SCAD, but then how many cases you have available, let's say, from calcification and normal?
Yeah, I mean, we have tons of angiograms that we have access to, and so it just has to be pulled and anonymized. It's something that we can definitely apply for to get. We do 3,000 angiograms of VGH per year, and our storage goes back. I can pull out anybody's angiograms in the past, say, 5, 10 years easily, and so we got lots of patients with cholesterol. But that's not the issue. The issue is trying to find angiograms of people with SCAD. And I also have collaboration with the SCAD registries throughout the world. So there's UK group, there's Spanish group, there's American groups, Australian groups, and we can probably run up together up to 10,000 SCAD. Obviously, that takes some work in terms of trying to accumulate that. It's possible. Mm-hmm. Like if we have a way to do this and we lead this, I would get lots of collaborators on board to do this. Okay. And
the problem can go in I guess from a technical development point of view in many different directions. You can basically say, let's say your normal angiograms are an order of magnitude higher in sample size than the SCAD angiograms, in which case one approach to tackle is just learn what is normal and then figure out what is abnormal. The other way is to make it a, let's say, multi-class classification of the normal versus classification versus SCAD. And then the other type is making it a grading system within the SCAD category. I guess the challenge that I guess I have in terms of the commercial need for this is that this specific procedure that you're describing is very, very specialized. I mean, I can't do it, obviously. It needs many years of training. So do you anticipate, let's say, people who are, let's say, fellows, the senior fellows in your team, do you see that they actually have problem to separate classification from a SCAD, any type of a SCAD, versus normal, or no, that is normally doesn't happen?
Yeah. So number one, angiogram is done by specialized cardiologists, okay? But it's a widely available tool. Any hospital that deals with heart attack patients typically have an angiogram laboratory. and train cardiologists to be able to do that. And so in terms of interpreting angiogram is a different story. I mean, you can try and interpret angiogram. Yeah, a fellow can try to interpret it, or residents, or even people who are not cardiologists can try and interpret it, but we don't expect them to be able to interpret. We expect the angiographer who's doing the procedure to be able to say, is this SCAD or not SCAD? But even the angiographers who are trained to do this are not able to do this in a lot of cases. And but I would say this angiogram modality is a widespread tool available in all hospitals who are dealing with heart attack patients. Maybe not, say, in Surrey Memorial, where it's a more peripheral hospital, it's not a teaching center, where people, when they have heart attack, they go in the emergency room, but they don't stay there. They always go to, say, Royal Columbian or Vancouver General, St. Paul's, to have their angiograms done. So the major hospitals, I would say all teaching centers, would typically have an angiogram suite like this that can diagnose heart attacks. Yeah. And in terms of your separation, that's what I was pulling up this work by the Chinese group, and because they've done that, like they have tons of normals they looked at, they have cholesterol blockages they have looked at. So maybe this is some way of collaborating with their group to learn what the algorithms are, and then we do our SCAD algorithms over here. So maybe there's some way that could be learned from what their work is already done without having to replicate all the angiograms, the normal angiograms and the cholesterol angiograms from our side. Something to consider. I'm not sure if that's feasible. I know Alexandra Lansky, she's reliable. She's a pretty established cardiologist in the US. I forget where exactly, but she's done a lot of work in the field in cardiology, and she's reliable. And I just don't know the Chinese group, but I know that they're a major center in Beijing. So.
Okay, because in the field of AI, many people share their models, even though they may not share their data. Their models, some people share. And one way maybe to collaborate with the Chinese group is that, can you send us the model that you have trained, and then we run it on a large amount of data here, and we actually independently assess how those models work. Because what our experience is that they always break down miserably. But we can see how they work. I mean, it's also fairly straightforward to replicate the model if the details are in the paper. So that's not that challenging for us. I guess from a publication point of view, comes down to if that Chinese model solves the problem, then from the AI development point of view, there is less opportunity, I guess, to.
Yeah, so, but they don't have, what they have is the cholesterol. They don't have the SCAD, right? Okay. So what we're developing is very different. But what we should be able to develop is how to differentiate SCAD from the cholesterol, which build upon what they have rather than starting from scratch.
Yeah, I mean, the one thing, at least from their paper, is that they rely heavily on the segmentation of the vessels, and that normally breaks down miserably in a general sense, with all different variations of the anatomy and the image quality, kind of the fluoro. So. If I were going to solve the problem, I would solve the problem a bit differently than what they did. But I mean, it would be good to get a baseline, because that's what the reviewers later on expect to see, based on what the baseline would be.
Yeah, right.
Great. Is there any other questions from the audience, I guess, from the students who are on the call?
I got a couple of
questions. Go ahead.
First of all, thank you so much. Great talk. Learned a lot. So I have two questions. I work on a regional wall motion abnormality in echo with Parag and Christina. We're both on the call. So my question is, the first question is it, so am I correct to assume that if we detect regional wall motion abnormality in echo, there is, and then okay, so I also did some, the data that I have, I also did some, looked into the genders and all the demographics, and the regional wall motion, it was heavily a male disease in my data set, which it kind of like stood out to me, sort of like a 4-to-1 ratio.
Yeah.
So if we were to say, like, detect regional wall motion, if it's a female, like, what is the probability, and you might have had it in the slides, I might have missed it, what is the probability that a regional wall motion patient who's a female has got SCAD.
Yeah. So, as I mentioned, ultrasound doesn't differentiate what the cause of the heart
Right.
attack is, right? So
Yeah, yeah.
most heart attacks occur in men more so than women, right? Again, because it's more cholesterol. You see heart attacks mostly men. And, and when women have heart attack, they're a bit later in their presentation. They're about 10 years later, naturally. And also the other thing about the ultrasound is sometimes these wall motion abnormalities resolve and normalize, especially for the SCAD patients. So initially, when we do the angiogram, we see 85% of patients have segments that's not moving well, okay? But sometimes by the time they get the ultrasound, things might have normalized. So you're even seeing a even fewer proportion, 85%, that has that. So I would say that, the wall motion abnormality, it can be a feature of SCAD, but it won't be diagnostic of SCAD. Right? It's a consequence. It's a consequence of SCAD. But there's focal wall motion abnormality, and you haven't picked it up on the angiogram, you can then go back and say, okay, where is that wall motion? Is it a lateral wall? Because if it's a lateral wall, it's more likely a diagonal artery or an obtuse marginal branch that's doing this. Then you go back and look at the angiogram in detail for those particular arteries to try and see is there correlating to where the wall motion problem is.
Right. That makes sense. Thank you. And then my last question. So the angiograms that you showed, are these, am I correct to assume they're 2D projections?
Yes, they're all 2D projections. And
right. So
angles to see in different, angles to see, the arteries at different parts.
Right. So can you comment on how error prone the visual assessment of the, like if you were to look at it, how much does that projection cause potential errors in your readings?
Okay, errors. So it can, because you're looking at 2D, number one, some segments are shortened, some segments are a bit more elongated depending on which angle, right? So if you're looking from cranial, for instance, the front artery becomes elongated, but then if you look from the bottom, the front artery becomes foreshortened, okay? And then the other thing is the blockages can be eccentric, meaning it's not circular. So it can't be like a crescent shape. If it's crescent shape, if you cut through this plane, you're going to see the blockage being more severe than if you cut through this plane. So that's why we need to take multiple projections to try and say what is the most severe area, most severe angle where it's most blocked. And so let's say a 90% blockage can look 90% blocked, but 50% blocked in a different plane. But we would call it as a 90% blockage because we have to identify, we have to find the angle that shows the most severe blockage to call that 90%. That
makes sense. So for any given patient, you will have like a long video that looks at the image with like different angles. Is that correct?
But it's also operator dependent. Some angiographers, they may be lazy. They might just do 3 angles. Whereas some angiographers, they're cluing in and say, oh, I'm looking for SCAD. I'm going to take 8 different views of this artery for multiple projections. Because the more you look, the more you're able to find. But if you don't clue in, you just do your standard 3 or 4 views and you might miss it, right? So it's very much operator dependent, just like an echo is operator dependent, depending on how, where to put the probe.
Right, that makes sense. I'm just bringing that up, just going back to Prang's point. That's another, like if you were to do this automatically with machine learning, that's like a huge source of variability as far as the machine is concerned. Right, that makes sense. Thank you so much.
But we just have to pretend that we give the machine the best source that we have and see what the machine can make out. But you're right. What is like, if you put in chicken soup, you can't put chicken shit, you're not get chicken soup out of it, right? So you have to put in the good quality product to get a machine to learn the proper ways, but it's very true. Yeah.
Right. Yeah. Thank you.
Great. Thank you so much. We are over our time now, and Jackie, really appreciate your talk, and everybody on the call, please feel free to either reach out to Jackie directly or send me or Danielle an email, and we could make the connection. I think from a machine learning point of view, the dynamics of the images and the subtlety of the disease would certainly push the limits of what we have today in terms of the AI. But at the same time, that means it's a fantastic research opportunity, really, to work on, most likely get a tenure out of it for some, for some colleagues. So, so Jackie, I guess I will be in touch certainly, maybe with a summary email, and also if anybody else, including, I guess, Ramin, I guess, from one of the local companies who is also interested to get engaged, that would be great. Really appreciate everybody attending the talk today.
Wonderful. So Perrin, if I can just have an offline conversation with you later today, it'll be awesome, just to synthesize everything and sort of talk about next steps. And
actually, maybe after this call, I guess once everybody leaves, maybe we can have a quick summary. Yeah.
Wonderful.
Okay.
Awesome.
Great. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you.
Perfect. That's very helpful.
No, really amazing. Thank you so much. Danielle, do you want to stop the recording?
Yeah, I was gonna make you the host. I have to jump off, so if that
I'll
works.
join the other, I guess I have another actually AI career fair meeting as well, but I
Oh.
want to actually summarize this with the